Giving a talk on DNR orders in the suicidal patient. This topic came up on my talks rotation, and I figured it would be worth it to dive into this a little deeper, kind of from the ED perspective. So our objectives today are to discuss the ethical principles involved, focus on emergency department specific challenges, review legal precedent in the US, compare with international law, and familiarize ourselves with state law. The ethical principles that we all practice with are beneficence, non-maleficence, which some people call non-malfeasance. I found also, same word. Autonomy and justice. So we're going to keep these 4 principles in mind as we have our discussion, if you guys feel like discussing and interacting with us. I do want to say there are no right answers, even among all of the mental health specialists. There were a bunch of opposing views, so nobody is going to be 100% right or wrong in giving their opinion. The case that I'm presenting is actually based off of a real case. I just changed a couple of key points to make it relevant to the emergency department. 65-year-old female with a history of COPD, chronic back pain, major depressive disorder, is found unresponsive at her house by her aide. At the time of discovery, she's clutching a rosary, a signed DNR document, and the calling card of a funeral home, which is like super dramatic, but it actually happened. By the time she arrives in her ED, her respiratory rate is 4, and she has pinpoint pupils. Her aide arrives kind of at the same time and tells you that she thinks that she overdosed on her pain medication. Almost at the same time, your patient loses pulses, and this is happening in minutes. What's your next move? I actually want to ask maybe some of the attendings if they have any thoughts what they would do in this situation.
Yes. Does she have DNR?
She's clutching it. She's holding it. She's holding the DNR. It was obvious she tried to commit suicide and she was planning on dying.
I'm sorry, go back. What is there?
I didn't know I was that boring. 65, with a history of COPD, chronic back pain, depression, and we know she overdosed with opiates. So
I would do that. I would start CPR with the market. I would too. And this, I think most people probably would in this scenario. It's difficult, but I think most people would probably like. It's one thing. It's a tough thing. That this topic, I think, would probably have a lot of conflicting things. I think this one, I think I would do CPR.
She doesn't have an immediately life-threatening condition.
Right.
Except like suicide.
Yes.
So suicide. A lot of people have that. Suicide.
Right.
I mean, from the information you give us, it seems like it's all surrounding her depression and mood. So that it's not like this is like a tide of care on assisted suicide.
I mean, we stop people from committing suicide all the time. Yeah. So what is the difference if they tried it and we stop it versus we stop it before they try it?
Right. Yeah. So a lot of the attendings are saying that they would do CPR because this is obviously in the context of suicide. And we do usually stop suicidal attempts. So this is kind of what I came up with too after thinking about it for a while. And I started thinking, how much of her demographics are you taking into account with this decision right now? Just keeping it obvious suicidal intent, no terminal illnesses. Would her age make a difference?
Spring chicken.
Yeah. I mean, what about her comorbid conditions? If she has psychiatric history, you know, if someone doesn't tell us that she's depressed, but we still have obvious suicidal intent. So this kind of brings up a lot of tension between 3 of those tenets that we were talking about. Patient autonomy, we want to respect patient autonomy. We've come a long way from being paternalistic in that sense and believing that we know what's best for the patient. We try to do a lot of shared decision making. But how can we do that if We also have vowed not to do harm and to do good. So when we see someone in front of us that's sick and that needs help, our instinct is to help them, especially something where we know it's easily reversible and we have the antidote.
Also for the medical reports, shouldn't have capacity.
Right, yeah.
Right.
Yeah.
So for me, that was easy.
Yeah.
Capacity. So we don't allow people who don't have capacity to have autonomy. That's the definition.
Right.
So she didn't have autonomy at the time we saw her. Because I believe she didn't have capacity.
So Dr. Sinnert is saying, for those at home, that a patient committing suicide does not have capacity. So you would go ahead and do CPR. Some people believe that all suicidal patients do not have capacity. It's not actually a universally held belief. And we'll get to that, it's on another slide. So how would your management change in each scenario? You find out she's attempted suicide 3 or 4 times. This might, if you're someone who wasn't going to do CPR, maybe you would. If you were someone who would do CPR, maybe you wouldn't. For me, it didn't change my answer too much. Instead of 65, she's 85. Her major depressive disorder has been successfully treated for the past 20 years, and this is her first instance of trying to commit suicide instead of like her 4th. Her major depressive disorder has been refractory to all treatment, or she's on hospice, or there's already an old DNR on file. How would it change if she was on hospice?
If she's a terminal illness.
Yes.
She was going to die in 6 months and she's on hospice. That would affect.
Right.
I agree. I think that's the one thing I can think of who has terminal MS, that may affect them. Agreed. Everything on here not changed except the hospice thing, depending on the story.
But then would you document like not starting CPR because patient on
No,
hospice?
no, I would say that the patient's DNR.
I would say medical futility.
So this case comes from a case report. In the case report, details stay the same, but it actually happened at a psychiatric inpatient facility. I guess nobody was watching her, or they didn't go through her stuff. And she had all of her narcotics with her, and she overdosed on them. She was voluntarily there, actually. And she was holding onto her DNR, her rosary, and her funeral calling card. There was a lot of discussion in the moment, whether to honor the DNR or not. They decided to not honor it. They disregarded it. Patient was revived. While in the inpatient facility, the patient's PCP reinstated the DNR because they had a different opinion about patient autonomy in this particular situation with suicidality. The psychiatrist was pretty upset about that and requested that the ethics board did review to suspend the DNR during her treatment at the inpatient psychiatric facility. So the ethics board did review this case. They came up with a couple of points. She had clear suicidal intent, as evidenced by the fact that she was holding the funeral calling card, the rosary, and the DNR all together. They were very symbolic. The DNR was considered a part of the patient's suicide plan. It wasn't just an independent decision. It was actually very much connected to her suicidal intent. In their view, suicidal intent means disordered thinking, which means no capacity, which is what Dr. Sinnert was saying. And suicidal patients are considered vulnerable persons, and it is our job to protect them. And she had no immediately life-threatening or terminal conditions. So they did suspend her DNR, which is in line with what all of us were saying in this particular instance. You have to consider the reversible circumstances when somebody is coming in with a DNR and committing suicide. Even in cases with hospice, I did come across a couple of case reports where potentially the patient just didn't have adequate access to mental health resources, or they had uncontrolled pain that just was not being addressed in their plan. In fact, one of my patients last week came in because their hospice nurse was out for the week and they just hadn't had anyone replace them, and they had no access to any of their pain meds. Unjust living conditions, so maybe being homeless, food insecurity. These are all conditions that can be reversed, and potentially with that, the patient may no longer feel the need to end their life. And this is a question that we were addressing earlier: can suicide ever be a rational decision? So in the context of hospice, maybe when there has been evidence that the patient has been considering this for a while and they've really thought it through. A couple of states have passed medical aid in dying. Then in the Netherlands, which we'll talk about, they've passed laws, euthanasia laws. That's what they call it. That's their terminology. And it's medical and psychiatric euthanasia. So in the Netherlands, they do consider suicide in the absence of physical terminal illness to be a rational decision. They basically believe that there's no difference between a physical or mental anguish that has been refractory to treatment. But for us in the emergency department, is it really reasonable to expect us in the moment to dive through all of these ethical dilemmas in the moment right before we decide to revive someone? So considerations for us specifically in that moment. Advanced decisions are about more than a simple assessment of capacity. It's about consistency over time, understanding what it means for you and what the actual outcome is. This is something that maybe we can't do in the moment when we're meeting the patient for the first time on the brink of death or even dead. Length of time needed to consider all evidence versus rapid decision-making in providing care. Increased gravity of clinical decision. Conflict with colleagues or staff participating in the patient's care. So even though we were saying that maybe for someone who is on hospice, we would document medical futility, there may be some people that we're working with who would feel really strongly against the ancillary staff or somebody else who you haven't really discussed with, and that could cause a lot of conflict when we're deciding to make that judgment call. And then it's a highly emotive decision. This is something that maybe is a little bit different from just having someone with a terminal illness come in with a DNR. And then there's no institutional protocols or legal precedents that mention suicidality with a DNR. So if we do decide to do something a little bit more, we decide not to honor the DNR, or we decide to honor the DNR, there is no institutional support. So legal considerations, medical aid in dying versus suicide. So like I said, in the US, we call it medical aid in dying. It's specifically refers to patients with terminal illness with less than 6 months to live. There's a list of approved conditions, so it can't just be someone's really old and we think that they're gonna die in the next 6 months. And it prohibits specifically assisting with suicide. In the Netherlands, as I mentioned, it's open. So yeah, they call it euthanasia. It's available to patients who are greater than 16. So when they're 17 and 18 years old, or 16 as well, they are able to consent on their own, though usually their parents are involved in the decision making, but ultimately the 17-year-old has that decision. Unbearable suffering without prospects of improvement is one of the conditions. The second condition is there is no reasonable alternative. So usually they will have to prove that they failed other treatment methods. And the primary physician has to consult an outside physician, but they don't have to actually follow the opinion. And then it doesn't get submitted to an ethical review until after the patient has been euthanized. So yeah, there's a very provocative article in the Atlantic about this. There was a woman who was quite young, I think she was in her 50s, who after 12 months of grieving for her husband, petitioned for psychiatric euthanasia and was euthanized for prolonged grief. Yeah. So this is just something like on the very opposite scale of what we're used to or what we do here. Just showing that, there are a lot of opinions about this and depending on the culture. So legal definitions, we're all very familiar with this. Do not resuscitate is an order not to attempt CPR in the event a patient suffers cardiac or respiratory arrest. And CPR, the definition of CPR excludes measures to improve ventilation and cardiac functions in the absence of arrest. So if a patient comes in with a DNR, but they're having some kind of arrhythmia that you can shock them for, that still actually is appropriate to consider. Right. Yeah. So I think we've heard a lot of these cases where patients have sued for battery or damages done when their DNR is ignored. We've seen a bunch of these articles. None of these have been in the setting of suicide though. So there isn't actually any legal precedent. Furthermore, these were not in New York. I believe New York has a little bit more coverage for the physician. So in New York, this is for non-hospital DNRs. There is no criminal or civil prosecution in the following instances if you're honoring reasonably and in good faith a non-hospital DNR that someone puts in front of you, or if you're disregarding a DNR for two reasons. One, you believe that in good faith it has been canceled or revoked, or there's impending physical confrontation by the family due to objection. So that's actually, you're not liable under that. There's a whole other paragraph where it just repeats the words reasonably and in good faith a lot. So basically in any situation, as long as you acted in a way that's going to be seen as fair or other people in your position would have done, you're covered. This is New York State specific. Oh yeah, in the laws, there's no actual mention of what to do in a patient with a DNR in cases of suicide, iatrogenic cause, or reversible high likelihood of good outcome, like carbon monoxide poisoning or hypoglycemia or choking. So there have been cases where there has been iatrogenic cause of cardiac arrest during surgeries, and then the doctors, I guess due to guilt or feeling that there's something reversible, they will disregard the DNR in order to resuscitate the patient. One thing to note, in-hospital DNRs do not expire. Out-of-hospital DNRs expire every 90 days. So you have to make sure that it's current. And this is the form that we use in New York. It's the only form. It has to look like this, and it has to say DOH 3474. This is the most current one. In conclusion, it's a very contentious topic. There's no legal precedent. There's a lot of ED-specific challenges that complicate any kind of available ethical precedents that we see. Most of those are from non-ED situations. There's variations in reasons for suicidality, such as terminal illness, that may not be obviously apparent to us in the moment when a patient comes in. And there are a lot of case-by-case considerations. Finally, if you do have a patient who has a DNR on file who's coming in for suicidality, consider addressing that with the staff ahead of time so everybody is on the same page. Those are my references.